also share with you any materials, including the presentation, and that'll come along with the closed captioning transcript and Lisa's presentation and any other materials that we do. And I am going to hand it over to David to introduce our speaker for today. Oh, and I'm sorry, I haven't told you yet, but if you could please mute yourself, I would greatly appreciate it. I'll be going through and muting folks, and that way we can avoid any technical difficulties and everybody can hear the speaker clearly. So if you haven't already, mute yourself, and then I'll go through and do the same. I greatly appreciate it, and here's David.
Thank you, Jess. Jess had talked about having an action-packed agenda. I also think it's a very timely agenda as we talk about maximizing partnerships with managed care organizations. We're really fortunate to have Lisa Mills with us. Lisa is a friend to Iowa. She's worked behind the scenes as well as in front of the scenes to help us get to where we're at today and will help us get to where we want to be at tomorrow. Dr. Mills is a consultant on employment policy and systems change. In the early 2000s, she helped found and served as administrator for People First Wisconsin. This took on employment and reform of subminimum wage and was really a key part in researching and identifying nationwide best practices and making recommendations for increasing integrated employment outcomes for people with disabilities. In the mid-2000s, she served as a lead staff person with the Wisconsin's Managed Care and Employment Task Force. She led state initiatives around customized employment, systemic instruction and outcome-based reimbursement, as well as Wisconsin's CRP rebalancing initiative, which supported shelter workshop and facility-based day service providers to transition to a primary focus on integrated employment services. She serves as a subject matter expert with the Office of Disability and Employment Policy. We've been fortunate to have her spend quite a bit of time working here in Iowa with us, and she currently works with a lot of states on waiver renewals, policy and funding models, and really how to support service provider capacity building and engaging the workforce system by partnering with Medicaid and vocational rehabilitation. I could go on, but I think we'll stop there because we want to hear from Lisa. So Dr. Mills, welcome back, and we'll turn it over to you.
Thank you, Dave. I'm very happy to be back talking with Iowa. I miss everyone in Iowa. I do think we have a special event, so I'm going to turn it back over to the people handling that.
Thank you, Lisa. This is Jess again, and I'm going to hand it over to David's trusty sidekick, Leanne Russo, for just a quick little birthday presentation.
Jess?
Yes,
Jessica?
ma'am. I'm here. Can you
Screen?
It's there. Do you see share my screen?
No, I don't.
Well, Brad.
I don't see it.
Do you have the...
I just see the maximizing partnerships. I'm really sorry.
Do you have another window open?
Oh. No. No.
Well.
All right, I guess we'll just go on with Lisa, and it'll be more entertaining anyway. So maybe we'll try and, oh, wait, just a minute. No, we don't see the share screen. We can see it, but I can't. I'm afraid to click there. Should I? Okay. No, we can't get to the share screen, so.
All right. Well, do you want to wish David a happy birthday?
No, I don't. Now I'm mad at him.
I know. Okay, sorry. Back to you, Lisa. I'm going to
the
presentation. We tried our best, didn't we?
Well, we do want to wish David a happy 25th birthday. So I'm happy to talk on this topic today, mainly because I finding more and more that managed care is the way of the future, and more states are moving to using national health plan organizations for managed long-term services and supports. And so this is becoming the way of the future, and I really think there are opportunities, if we can seize them, to create more momentum around employment first. So I do come from the state of Wisconsin that has had managed care for 16 years, but we are a home-based, homegrown system that is now moving towards using health plans. I also work in Kansas, Tennessee, Michigan, Colorado that have had managed care. So this is our new reality. If you could go to slide 2, I just drew this model because, you know, we're all looking for ways to advance employment first. And the question is, in Iowa, I think, will the combination of employment service redesign, the new changes that were just being implemented now, the CMS settings rule, and the coming of managed care really advance employment first in Iowa? And if we have any control over that, what can we do to make that so? If you go to slide 3, I'm not going to spend a lot of time on the CMS settings rule. I assume you are, most folks on the phone are aware of it. But of course, we want to point out the strong endorsement of employment first in expecting that all home and community-based service settings provide opportunities for people to seek employment and work in competitive integrated settings. And I think one of the things I want to stress to you is that these health plans across the country in the states that they are in are being asked to help ensure compliance with the rule. Not only initial compliance by March of 2019, but also they are being charged with ensuring long-term compliance. And they take that compliance very seriously. I think they are being influenced by how other states are tackling the rule, and they get that integrated employment is a very important value and an important priority in a growing number of states. Next slide. For me, the big question, if anybody asks why would we support integrated employment, is what employment service would best meet these setting standards, without question would be fully compliant with the setting standards. And that is only individual integrated competitive employment. Anything else is going to be put under scrutiny. Next slide. A lot of folks are asking there in my state and other states, why managed care? Why is this supposed to make things better? And I think one of the things is understanding to help advance employment is what are the goals of managed care that are in alignment with employment. Obviously, the goal, that what they believe is by providing integrated care, so having one entity that manages the acute and primary and behavioral health care along with the long-term services and supports, that we can get better outcomes and improve coordination and reduce duplication of services, and then that would allow us to save money but also have people experience better outcomes. They believe that the silos of the system have caused poorer outcomes and duplication and more cost. It's not an unreasonable argument, I don't think, but one of the reasons why I think it particularly benefits employment services is because some of the savings and some of the outcomes that we know occur when people go to work are about health and mental health. And those are the things on the other side of the equation. They aren't long-term services and supports. They're the acute and primary. And if you don't have a managed care organization that's also managing those pieces, they may not see the value of investing in long-term services and supports to create savings on the acute and primary behavioral health side because they aren't actually responsible for that side. So in a sense, by putting it all under an MCO, they can do things, they can invest in things on long-term services and support that will yield savings on the health side, and that will make sense to them. Next slide. So another question that's often asked is, why are these national health plans who really do commercial insurance, why are they interested in Medicaid managed long-term care? And again, the reason is that they are, in many states, have already taken on the Medicaid acute primary care side. They're already managing that. And they understand that long-term services and supports is another piece of the puzzle that actually can really influence health. And so they think they can do a better job with people if they have it all under their umbrella. And they're starting to recognize that actually the things they do with long-term services and supports can actually have a lot of impact on people's health. If you go to the next slide, there's a pie chart, which is really summarizes the real commentary that's going on between health plans and state Medicaid agencies right now. The recognition that health is really driven a lot by our social and economic circumstances. Not so much about, see, clinical care is 10%. So the actual things like buying health care isn't really what indicates what people's health is. The biggest factor is, where do I have a job? Do I have income? Do I have a decent place to live? Am I socially connected or socially isolated? They're recognizing that all of those things are what really drives people's health. And those are the kind of things that long-term services and supports can actually influence. And it's great to see the research saying that employment and income are two of the biggest drivers of health. So if you go to the next slide, my next big question, why would a managed care organization want to purchase supported employment rather than the other services that are on the menu? If you go to the next slide, one of the things that influences them is the federal government. And the federal government has been increasingly putting out guidance and regulations about how managed care should work. In part, it's a response to the fact that some states have gone to managed care very quickly, and I know Iowa probably falls into that category, but in the past years have gone into it, and there's been not enough safeguards in the view of advocates and others. And I'm not talking about Iowa because it's too new, but some of the other states. And the federal government has reacted by saying we need to put out more guidance and more regulations about how states can use managed care to make sure that it's actually implemented and it produces better outcomes. And the good thing is that when CMS got the chance to issue guidance, they didn't leave that opportunity to promote employment. And so we see both this guidance that's on this slide that came out in May of 2013, and now the new managed care regulations that were just released a few weeks ago are all reinforcing the idea that employment and opportunities for competitive integrated employment have to be part of what managed care is about, especially managed long-term services and supports. So there's no question to states, I think, or to health plans that employment is an important part of this. And those quotes are taken directly from the guidance. But I think some better arguments that you all can make, if I'm talking to a group of supported employment providers, which I hope I am, is to make the arguments that the health plans already know, but it doesn't hurt to further educate them and reinforce with them. So if you go to slide 10, there is a very strong case for integrated employment and the benefit it would have for a managed care organization. The first thing is the health outcomes. And the clear evidence we have in research that employment contributes to better health and that better health contributes to participation in employment. So it's considered, the researchers call it bidirectional, but basically it means employment and better health are mutually reinforcing things. So for a managed care health plan, whose really primary focus has always been health outcomes, employment is a key tool for that. And the evidence we have in the mental health field about employment being a tool to prevent mental illness and to actually contribute to recovery. That is actually a form of treatment. Again, they are hearing a lot about that, and they are embracing that. And there's an awful lot of folks who maybe don't have mental health as their primary diagnosis, but may have mental health as a co-occurring condition. So we're seeing more and more evidence of that in other long-term care populations. So this becomes important across the board. The last finding on 10 from the literature is that when people are employed, they have greater skills for the things we call activities of daily living. That translates to potentially needing less support at home and in the community on an ongoing basis. If you go to slide 11, other things that are really important to stress about integrated employment is it's one of the few outcomes that a health plan or a managed care organization can support where there are other systems out there who have a role to play in supporting employment. So they can leverage resources from other systems to help managed care members achieve employment. VR on the line introduced me today is obviously one key system, the workforce system, and now you were seeing with WIOA the tremendous emphasis on employment that's being funneled into the school systems. So there are very few other services like that where you can say there's other systems out there that can also participate in supporting people. It's also integrated employment is one of the only things that actually get people into a position where they have an opportunity to develop and utilize natural supports. If I am delivering services in a setting that is a setting for people with disabilities where the only people there are people receiving services and case staff, there's virtually little to no option to actually help people develop and utilize natural supports. But when we pursue employment, we have that opportunity to develop that. Also, employment enhances income. It's all the other things people can do with their time will not enhance income, but employment will. And one of the things that people can do, you know, we don't want people to have to give away all their income to their supports, but with the Medicaid buy-in, there is a sliding scale where people who earn enough money can begin to contribute a portion of the cost of their supports. And I think that's something that is an important to highlight in terms of going forward with employment as a priority for managed care. And then the last thing is, as we help people increase the amount of employment they have, and then we try to help people get better jobs, there's a chance that people will be able to access employer-sponsored health care, which of course is the ultimate goal in terms of a Medicaid system and a health plan, thinking about people being able to get health insurance, at least covering part of their needs through employer-sponsored programs. All of these things are specific to employment. They're all important things that would resonate with a health plan or managed care organization. They wouldn't necessarily know this unless you point it out and reinforce it to them, but there is a growing knowledge base within health plans around this piece and the need to really focus on employment. The last slide 12, I'll just go over in terms of the national emphasis on employment first and the worry that managed care or health plans might somehow reduce that emphasis or reduce that momentum. My work, I do work with some of them. I consult with them because I feel like if states are going to do this and they're going to use them, I want to, have the best possible outcomes in the states that they are in. And I must say that they get that the national emphasis on employment first is growing, and that they are expected to be full partners in that. I don't believe that you would have that kind of any kind of resistance to that. We've seen some of them, their project search sites, they're doing other types of innovative things about employment. I think you have one health plan in your state that proposed value-added benefits that are around supported employment. So they are getting the message. They don't always understand how do we make it happen for people, but that, I think, is where your expertise is as networks providers and people committed to this. They also are really sensitive to the fact they know youth and their families want something different from the long-term care system, and they recognize that they have much higher expectations around employment. And the good thing, I think, is that these health plans, at least a couple of them that you have in Iowa, 2 out of the 3, I don't know everything about all the health plans, but 2 out of the 3 are in other states that are already requiring them to focus on improving integrated employment outcomes. It's in their contracts. There might be pay for performance, or there are other requirements that they have specifically to increase integrated competitive employment outcomes. So they are coming from states into Iowa already having states expect this of them. Slide 13. What are the things that might cause an MCO to be reluctant to purchase supported employment? I think this is where our work, your work in educating and reaching out to MCOs is really important. If you go to slide 14, they do look at what is the most cost-effective way to support people, and if supported employment rates appear to be substantially higher than alternative services, and if they expect that the utilization of supported employment would be the same as the alternative services, and the outcomes wouldn't be that much different, I think that's going to raise a red flag. Now, we all know if we do good supported employment that the utilization is not the same as those alternative services, and that the outcomes are significantly better. But I think you're going to have to do that education and show them through examples why supported employment is a better option, even though the investment on a fee-for-service rate basis may look different to them. The other thing I think they struggle with and they need help with is that they don't always know how to deal with members who are saying, I don't want to work. I'm not interested in working. I don't think I can do that, or whose families are saying no. You can only deliver the services that are authorized, and in the planning process becomes really critical. And if an MCO is struggling with getting people to agree to get out and explore the opportunity and to agree to pursue work, that becomes a big challenge and could be a barrier to increasing the use of supported employment. They need help with that. It's not that they don't want people to say yes to work. It's that it can be quite a challenging thing in those planning processes to achieve that. If you go to slide 15, some of the things we've learned, I guess, I've learned in working with some of the health plans, is that if the support coordinators or service coordinators doing the plans don't have enough knowledge or experience with supported employment, that makes it even harder for them to convince people to give it a try. And there are also other drawbacks if the service authorization process for supported employment is more cumbersome, or the service coordination takes more time if somebody chooses supported employment. Those are all things that if they're real, we have to deal with them, because it's going to create an inadvertent disincentive for a MCO service coordinator to encourage employment. The other thing I think we've seen is it's hard if supported employment providers aren't willing or able to offer the holistic supports to people, because the same way I was talking about silos at the systems level causing problems, silos in service delivery also cause issues for continuity for people receiving services and for support coordinators trying to convince an individual or a family to pursue employment. So to the extent any support employment providers listening can embrace the idea of providing these other wraparound supports, it means that you'll be able to offer that whole package to people so that you'll be the one that can adjust their wraparound supports if there were shift changes or if they have a dip in hours or a sudden increase in hours. And all of that makes it easier for the person, the family, and the support coordinator, and I think can encourage more use of supported employment. Next slide, how can supported employment providers help MCOs? I know it's a very rough time at the beginning. You might, there might be a lot of frustration, but I think the MCOs are open to receiving assistance and want to partner with providers. I think pointing out on slide, sorry, I lost my page numbers here. Slide 17, integrated employment is everybody's business now. I think that is there's a great opportunity in the settings rule, because this expectation around providing opportunities to seek employment and work in competitive integrated settings actually applies to all services and all settings, not just employment. That there is an opportunity to help the MCOs understand what should they be expecting of providers of non-employment services. The ones that come to mind for me, residential, transportation, day service supports, what do they need to be expecting so that those providers and the way they do things is not a barrier to people seeking employment and working in the community. I've heard far too many stories from supported employment providers about residential agencies or transportation providers not supporting the job as a priority and people not being ready. On time or not, what their role is in supporting people to work. But I think the health plans agree with that, but they might not necessarily be able to define, so what should we expect? What should we put in a contract for a residential agency or a daytime support provider that's non-work services? What should we expect? Good examples of that I think would help. Next slide, helping the managed care organizations grow the supported employment services that they are purchasing. To me, everybody says, well, we should be spending more on supported employment, and it all goes back to the plans that are being written. That's what dictates the services that are authorized and then the spending that's being done. So to grow supported employment investment, we have to have a way to help them work with the member and the member's family or guardian to say yes to pursuing employment. And you all, I mean, you're fortunate in that the employment service redesign changes include this exploration component for people in pre-vocational services. And hopefully that would be available to other people who maybe aren't in pre-voc but need that same experience to get them to say yes to pursuing employment. That's going to lead to authorizations, which is going to lead to the rebalancing of the investment of funds towards supported employment. The other thing I think health plans need help with is how and when do people engage IVRS, and when should they be prepared to take over from IVRS. And sometimes providers are really good at knowing how that would best work in practice. Although I know your VR agency is stellar in the country in terms of engaging in this partnership and wanting to make it work. So but I still think that the health plans and their service coordination staff need to understand if we're going to leverage this VR system, how do we actually do that well for people? The last thing is, with employment service redesign, they are, as I understand it, health plans will be issuing updated contracts because of the change in rates and services. There's an opportunity here to talk about what kind of provider contract provisions would actually incentivize or reward you as a provider, if you are a provider, to deliver best practice supported employment. Oftentimes, it's hard to see in typical contracts with providers where the incentives are to do best practice supported employment. And so sometimes the providers are actually in a really good position to be able to say, you know, if this were part of the contract or that were part of the contract, it would really help us. And so, I mean, you can make those suggestions at any time, but there is some contract changes are going to be happening now because of redesign, or the suggestions could potentially be integrated into the next annual renewal of the contracts. Health plans are very interested in performance-based types of approaches, and they are used to that on the acute and primary side, working with doctors and other providers of health care. So it's not foreign to them. And if you have a concept for that you think would work for supported employment, I think you'll find them more receptive than the old traditional folks who did contracting, who really didn't have that kind of frame of view for getting good outcomes for people. If you go to the next slide, more about helping MCOs grow supported employment. Again, I'll go back to the extent supported employment providers can offer holistic services, not just supported employment, but to offer the other services that wrap around that. I think it will help more people be comfortable choosing supported employment and having that in their plan. And the kind of things that people need is what am I going to do with my time while I'm seeking a job? And I call those in the meantime services. So while people are seeking a job, and if they need support, who's providing them and what are they doing? And a lot of times I think people went into facility-based programs or non-work programs because they needed a service, and the job was, it was going to take some time to get a job, and it was down the road at some point. So meanwhile, they went into these other services, which really, you know, they were not necessarily focused on that support employment job as the ultimate outcome. So I think if we have support employment providers willing to provide those in the meantime support, we don't lose the focus on the job as the ultimate outcome. The other thing people need often if they work part-time is wraparound supports, supports for the rest of their week or part of their week. And again, if a support employment provider can do that, that's going to make it much stronger continuity for the person. Sometimes people lose their jobs unexpectedly, and they need to have supports to do something with their time until they find a new job. And again, having a support employment provider who can provide those supports in addition to helping them find a new job, I think is really important. And the last piece is really the transportation piece. And because that is separate now from support employment services, there's an opportunity, I think, for providers to be really creative about how people could get transportation and be part of, you know, generating some solutions around that don't necessarily involve the agency or the staff doing that if it's not the most cost-effective way of doing things. All of those things, I think, would help grow supportive employment and the ability to purchase more of it and have more people agree to have it in their plans. The next slide, I think it's slide 20, ways to partner with MCOs. These are things that again, based on experience, that I would do if I were a support employment provider. The one thing I think they need is training for their staff. They need more training content on supported employment and pathways to supported employment. And I believe that providers are one of the best sources of that training to help them understand what best practices are, how people can get jobs, how to deal with people who say they don't want to work. All those things, I think providers can do a lot of good. The other thing, we've seen them in other states become project search sites. If you are a provider with experience with project search, offer to partner with them to be a project search site. Another thing, if you are a provider who's done customized employment, you understand employer needs analysis. And I have seen providers approach managed care organizations about employer needs analysis. And the MCOs ended up hiring one or more supported employees into customized positions. They should be an employer as well as a funder of supports, and this gives them an opportunity to do it and at the same time learn about customized employment. The last thing I think is that these managed care organizations are customers to many businesses in state and nationally. They are their accounts payable list. They are the businesses that serve MCOs, whether it be auditors or suppliers of office supplies, you name it, insurance providers. They are all businesses that want to keep the health plans as their customers. And I think there's an opportunity to reach out to them around hiring people with disabilities. And the managed care organizations are in a good position to bring those suppliers in because they are their customers. Next slide. Other things that I wanted to talk about, contracts really matter in the managed care landscape, or whatever you want to call it. The contracts between the state and the managed care organizations are taken very seriously and are essentially the entire agreement between a state and a health plan. So I think it's really important before you engage a managed care organization around these topics that if you can, you have a look at their contract. And I'm not saying you should read 800 pages, but what I do is a word search. I do strategic word searches of contracts. I look for provisions that would be in there that relate to employment outcomes so that I know what's already being expected of them by the state. And so that I can go in and say, you know, what I'm wanting to do or what I'm talking to you about doing can help you meet some of your existing contract expectations. I think that helps to understand what the state has said to them about their requirements. I said this last year, I think, at the APSI conference, and that was prior to the actual launch, but I would engage these health plans now. The reason, obviously, is the redesign changes are being implemented right now. You know, unfortunately, they didn't make it into the original implementation. There was a month delay. And this is all something that now the managed care organizations are having to deal with. Getting to talk to somebody who was involved in the redesign process, if you were, and there were certainly a lot of stakeholders involved, who can explain the history and explain where the ideas came from and why this redesign is being put in place, I think would be very valuable for them as they have to now adjust everything to incorporate the redesign and the new administrative rules into their practice. Next slide. I do think that the MCOs, part of helping them understand the redesign is part of helping them understand the validity of the new reimbursement rates. They need to understand that higher supported employment reimbursement rates will bring better outcomes for people served and more efficiently because you can hire better staff and deliver higher quality service. People will get better outcomes. They will get jobs more quickly. They also have to understand that integrated employment supported employment is not like other services that what we expect is higher costs in the beginning and lower costs down the road as a result of fading. And if that is something they haven't wrapped their head around, they need to understand that, because that explains and validates the reimbursement rates that are now being put in place. And overall, I think just constantly talking to them about the better outcomes for people who get into integrated supported employment, all the different ways that their life is enhanced. I think all of that helps reinforce that overall this is a good investment that has a lot of potential to help people with quality of life outcomes, which is something that they are measured on. Now I'm on the, I think, almost to the end now. Next slide is titled Value-Added Benefits. If you aren't familiar with these, I hope you are by now, but I realize it's, managed care hasn't been in place that long. Every MCO had to propose a set of value-added benefits that they would provide outside of their funding from the state. They were committing to providing additional services and support based on needs that they believe exist in the state. So I think it's really interesting for you, if you haven't looked, I put the web address, the web page where you can get a really nice document that shows all the value-added benefits that are being offered by each of the 3 health plans. Look at those and pick out the ones that are focused on integrated and supported employment, or have some connection to integrated and supported employment. First, so you know that they're there, and you can make sure that members who need those services are taking advantage of them, because they are being offered by some of the health plans. And then in light of the employment redesign, I would look at those and see if there's any changes that you would suggest. They created the value-added benefits based on the old model prior to the redesign. And so I think it's worth looking at and making suggestions about where they might take value-added benefits in the future, given the redesign that's being put in place. Next slide, final thoughts from me. I did want to leave some time for questions or comments. The transition to managed care is always a rough one. I cannot point to one state, no matter how slowly or how quickly they did it, no matter if they used in-state health plans or national health plans, it was a rocky road. And so I don't know how Iowa's going, but I'm guessing, I put most of my money that there's been some rough roads. The problem with that, unfortunately, is this is the time when you're developing your relationships as providers and as others with the health plans. You're developing your first relationship with them at a time when the challenge is so great and the road is so rocky. And I think it just creates, a possibility that the relationships will not get off on the right foot. And I think we have to make a serious commitment to say, look, these are our partners, these are our funding partners, and we've got to figure out a way to get through this really rocky time. If they are not coming to you around employment service redesign or expanding support employment, I would go to them. I have not found them closed or unwilling to talk, but sometimes, and I hope I'm not offending anybody who might be on here from a health plan, they don't always know everything they should know or they would want to know about supported employment. And so the dialogue just helps everybody start to understand each other, get on the same page, and figure out how to work together. And I know it might seem a little daunting for any single provider to go to a health plan on your own, but I still think that's possible if you're in their network. There have got to be opportunities, I'm sure, with this community practice or APSI or the Iowa Association of Community Providers to get together and make recommendations across the board to the health plans. Trust me, they are making recommendations to the state about what the state should be doing and changing and improving on. There's no reason why there shouldn't be that same kind of dialogue between support employment providers and the health plans. I think they want constructive partners. They want partners who can help them be successful, and I think in turn they will want to help you be successful. Second last slide before my contact information, I put this quote in: change is hard, but it's essential for progress. I like this quote: every good thing that has happened in our life happened because something changed. And I know this is a time to talk about, this is a time where you're facing just how hard change is. But I really believe that if we partner well on this, that managed care can actually propel employment first forward. So I'll stop there and turn it back over to David or whoever if we want to do questions or comments or however you want to handle it.
Thank you, Lisa. I want to make a couple of comments while I have the chance. We have a quote here from one of our local Medicaid experts that she shared, and I'll just read this, but it says, in December of 2012, the U of I Public Policy Center published their study of the cost of health care for people receiving Medicaid through the Iowa Medicaid for Employed People with Disabilities. They found that the Medicaid costs were reduced to $161 per member per month for enrollees entering MEPD from another Medicaid eligible category when Medicare enrolled members were excluded. So you talked a little bit about that pie chart of determinants of health, and I think this fits right into that we have some local data too that shows that when people go back to work, good things happen. I was struck by the 40% factor of the social and economic factors, and then you add in, the 30% for health behaviors. So over 70% of that is in the areas that we have some impact and control on. That was kind of a cool statistic. A couple of other thoughts is I really liked your quote of that everyone has got to be about employment. And we've talked about that for quite a number of years through our Employment First initiative. But then as you look at our conversations that we're having across systems to make sure that whether it's an MCO or another state system or a private system, that we're all working in sync to be about employment. I think that's a good challenge and a good opportunity. You also had a talking point about when to engage IVRS and when to take over. And I thought that's a really a key talking point, and we're struggling with that, I know, in areas across the state. And I would encourage people to not make assumptions about knowing when that occurs, because it's really based upon a local conversation, and where those conversations be occurring at the local team level, to have those decisions being made by the team with what you know about your job candidate. So it's not being dictated by a state policy, but it's really, there's flexibility in the system to have those conversations occur at the local level to really leverage our resources to support that. But it's important to get the team, and that would be all team members, together at the local level and having those conversations to agree. You also had a talking point on helping define contract service provisions that will incentivize and reward supported employment services. I think that's a challenge for us, and I wrote that down and put an asterisk by it because we've talked about how to do that. I want to stress for the participants in the phone call today that our system is new. I mean, we're just rolling this out over the last few months, and we recognize and have an interest in figuring out how we can look at incentives to make it work better. So and we don't really know how to do that yet. So as you have ideas or thoughts about that, please feel free to send an email or a note or call to myself or to Leanne Russo and get us thinking about some things, because I think as the next year or two rolls around, we do have intention to figure out and try to come up with some answers with that. So those are just, I'll get off my little pulpit here, Lisa, and I want to ask a question back to you. You had shared some talking points about how we can help the MCOs and some strategies with that. I'm curious to know, though, if you could pick out some pitfalls for service providers that we typically fall into as we're having those conversations? Are there areas that we need to be careful and not stepping on minefields? As you're listening and watching people across the country do what we're doing, are there other tips that you might share to say, hey, avoid these minefields, or be careful of maneuvering around them?
Well, I guess I would suggest you don't make assumptions about the health plans. I think, managed care has gotten a bad rap, and a lot of people assume that it's just about cutting plans and cutting rates to providers, and that's all these organizations care about. And I guess I just would be careful about not assuming that, and getting focused on outcomes with them, improving member outcomes, and then tying that back to, that, by the way, that saves money. But not, really making it about member outcomes and improving outcomes, because I think that is where they are at in terms of priorities. And the win-win situation for me is when doing something really good for a member saves money just because it's good. And, those are the win-wins that we want to really promote, and employment is certainly one of them, where you can talk about the value for the member, and by the way, here's the case for how it saves money. So I guess that would be my biggest view is, we have to be confident about the value of what we are providing, the services that you're providing, and the impact that has, and don't assume that they are simply going to, make decisions based on profits and other factors, because again, a lot of the safeguards that the feds have put in place, and some of these organizations, they've been selected because they voluntarily have put a lot of these safeguards in place, have to do with making sure that member outcomes actually improve. So that would be my suggestion.
You had mentioned too, Lisa, about the importance of identifying from the job candidate, consumer, family base interest in statements and wanting to work and wanting to look at employment. I know we have providers across the state that are going through transformation efforts, and they're dealing with changes, and our families and our consumers have difficulty with those changes also. Can I assume that we can take what you just said with the arguments about employment and the benefits and some of the things you've talked about with the health determinants and value of social networks, and those would also all be supporting communication backs that we could be using with our families and individuals with disabilities also?
I think so, yes. I think there's nothing wrong with promoting that those are outcomes, that not just a managed care organization would care about, but that those are outcomes that a family would value. And they often perceive that any kind of move to the community or employment is more a safety risk, and don't always see the benefits of what could actually happen for people. I often like to point out that a lot of unexpected good things happen for people when we get them involved in community, and especially in employment. And we don't always know those when we start, but those things happen as kind of bonuses to the work. And so I think the more you can be, if you put success stories together that are multidimensional, those can be used for families and for young people coming out of school, and equally used for the managed care organizations, and letting them borrow those stories, I think, and use them as they can be proud as a provider from their network who's responsible for these success stories. They can then use those with families too. I think the more we can get to the point where everybody around an individual and a family is pro-employment, the easier it's going to be for them to take a step towards it with us. and you get them moving in the right direction, and then you can get them to the outcome.
Well, Dr. Mills, thank you so much. I think you've really echoed a message that highlights the fact that we're in an environment with lots of opportunities to figure out ways to support individuals in their journey to competitive integrated employment, and we can all work together in making that happen. So we really appreciate your time and the work that you're doing, and the opportunity that we get to share a little bit of that with you. So thank you very much. Jessica, I'm going to turn it over to you for final comments.
Thank you, David. Thank you, Lisa. I've opened up our closing page with the polls and questions, the evaluation questions. We sure appreciate your feedback on those. Lisa, is it all right to go ahead and share your presentation as is, or do we need to make a couple changes to it?
No, unless you didn't like something I said, then you can feel free to edit.
Wonderful. No, perfect.
Share it as is.
Perfect. Not to imply that I needed to, but I just didn't know if it was okay in the format that it was. So I'm going to go ahead and upload that right now, and folks can download it straight from that left-hand pod over there, the file pod. Again, share your answers in the polling eval questions. And then since we have a little bit of time,